Hello everyone, I'm Lydia Davis and I'm just going to do a little introduction about the network. On behalf of the network. Before we each give a little bit of information about the work that we're doing at the moment. So the network of care home researchers was founded to support research in care homes due to a limited research evidence base in the area. So we've taken a unique approach with network meetings, at least before the pandemic, were held at Nightingale House. During and since the pandemic, they've been online, but that's meant that we could continue the work we've been doing. So the primary objectives of the network are to support and collaborate with both current and former researchers working with Nightingale Hammerson, with the aim of through research to improve quality assurance and standards for residents, but also staff. I think that's a key thing to be considering within a context of relationship-centred care. We are aiming to develop research capabilities and resources within Nightingale Hammerson as the host organisation, but also our findings can be applied to other settings as well, so they're very useful to the evidence base. So the network members include PhD students, research associates, research fellows, clinical academics like myself, and we're working in really diverse fields, including design, gerontology, nursing, and social sciences across a broad range of universities. And we're constantly adding to the network, and people are moving in and out of the network depending on what's going on in Nightingale Hammerson. So it's very inclusive and very flexible to the research that's happening, and we encourage anyone to join who's carrying out research at Nightingale Hammerson. So that's just a little bit of background, and now I'm going to talk briefly about the work that I've been doing recently in Nightingale Hammerson. So just a little bit about myself. I'm a speech and language therapist, but I'm currently working in a clinical academic role at City University of London. So I joined the network just before the pandemic when I was working on a feasibility study that was developing an intervention called Storytelling for Older Adults in Residential Settings. So the aim really was to improve social and emotional well-being by increasing communication opportunities and seeing if we could actually improve or support residents' ability to communicate with each other, interact, and actually work on storytelling skills to see if there was any change there. We started the project just before the pandemics, which was very challenging, but we were still able to carry out interviews and consultative research at Nightingale Hammerson, as well as some other care homes. And then we carried out a single group case study of the STARS intervention. So so I'm continuing to work on this STARS intervention as a broad project, but it's kind of moving in lots of different directions. And something that really became apparent when I was working on the project, I was working in care home settings, and I just thought, why are there no speech and language therapy students in care homes? Really, there's a little bit going on around dysphagia, but I thought really it's an amazing untapped resource of energetic, enthusiastic students who are really focused on communication and social interaction and social well-being, who can bring, energy. They've got the luxury of time to try things out. They can collaborate. They can interact with staff and residents. So I decided that would be a good thing to focus on. And Nightingale Hammerson have been so welcoming and so helpful hosting the students. So for 2 years in a row, they've hosted our speech and language therapy students, I think some of our nursing students as well, actually, on a longer term basis. But more recently, at Nightingale House, we've had started with 2 students, and then the second year we had 3 students in the spring term, so that's just once a week placement, and then in the summer term it's a 6-week block of 3 days a week, so it's quite a good opportunity to get things going there. And what we're really focusing on, because I'm practice educator, so I'm on site with the students, at least to get things started, and then the idea is to build sustainability by working with NHS therapists. I can see one in the crowd who I've been working with as well at the Care Home in Reach team at St George's. But linking research to practice. So I'm in the position where I'm across quite a lot of the research. So we're looking at ways that we can trial interventions and get things going, at least try them. As Ali was mentioning, sometimes it doesn't work, sometimes it does work. Enough of it is working and being really quite successful for it to give me hope and energy to keep going, that this is something we should be doing. So I thought, I don't have much time, so I don't want to go on too much, but I just wanted to just go over some of the benefits that I've noticed, and I think it's beneficial for everyone. For the residents, I could give a lot more detail on this, but actually the main thing is an increased interaction and communication opportunity. So by communication, I mean that in the broadest terms. So we could be talking about conversations and storytelling and going through personal stories and being person-centred and relationship-centred in care, but also just making connections. That could be non-verbal, that could be about facial expression, making a connection. And you can make a connection with anyone. There's no one that you can't make a connection with. So it's about really doing that detective work and that background work, finding out about life stories, speaking to relatives, speaking to staff. Staff has so much they're able to tell us. Because we're in this unique position of residents, working with residents, this is their home. So we can speak to staff who work with them all day long, we can speak to family members, we can observe them, and see what's happening in all those different environments. So it might be observation and an engagement opportunity, it might be during meal times, and we're looking there for communication, functional communication, conversational communication, but also communication breakdown. So communication is a two-way process. It's not about, this isn't working for that person, this person is being a problem. It's that something's broken down, so we need to look at both sides of the equation. And, jumping down to students, I think what the unique opportunities here is we have so many more resources and more information at our fingertips to do that detective work and really work out what's going to support. Say if we're, working with someone with dementia, finding out what's the best way to even just start an interaction with that person. If we know something about them, then we know that actually they're really proud of their cooking and they love talking about their, roast chicken and things they used to cook or would still like to cook. That might be a way in for someone, or it might be that there's certain things we can talk about that will actually reduce distress because we know for that person that it's quite comforting and reassuring. So there's a lot of detective work that can be done here. There's a really broad range of clinical presentations and learning opportunities, so it's absolutely perfect for students. So there's the dysphagia, eating and drinking and swallowing side of things, where we're generally having some students in care homes at the moment, but actually there's so much to be learning about the communication side of things across a really broad range of diagnoses. And it's an ideal opportunity to be piloting interventions. So, a lot of what Ali and Andrew are both saying, these are the perfect settings to be piloting interventions, and I would, be quite keen to pilot some of the sonnets outcome measure, because I think that would be really helpful for us. But that's something that students can do. We can just 2 minutes, sorry, I'll move on. We can get them to trial things, go through, do audits, going through files and seeing what referrals are being made, which aren't being made, why things are successful or not. So for staff, I think it's great because it can increase awareness of communication needs of residents, but also there's so much opportunity to collaborate. And for knowledge exchange, it's really a two-way thing. And the students have learned so much from the multidisciplinary team here. And, I think hopefully it's gone the other way as well, goes both ways. And generally for the profession, I think it's a really useful thing to do, to have the student placements here, because it raises the awareness of our role within care homes, which can be a bit of a mystery, I think, in some cases. And also it contributes to the expansion and improvement of clinical practice. It means that we're pushing and we're saying, okay, that's great that that's happening, but we can do better, actually. We can do more. And it's a great way of being on the ground and improving those, improving care, basically. So thank you. I will now pass over to Millie.
Hello everybody, my name is Lydia Davis and I work for the CRN South London, which is the Central Research Network, which is part of the National Institute of Health and Social Care Research, which I know you've all heard a lot about today already. So the National Institute for Health and Social Care Research's aim is to coordinate and support the delivery of high quality research which is taking place in the NHS and across the wider health and social care environment, and this includes care homes. One of the ways which we're providing support is through delivery staff, such as myself. So that's research nurses and practitioners. I'm a research practitioner. My background is in neuroscience, and I joined in June 2022. Who else? So the new team that we started is the direct delivery team, which focuses on underserved communities, which is how we've kind of ended up in care homes. So one example of the research that I have supported is the AFREC study. As I'm South London, it was the Nightingale House site that I did it in. And we were looking at portable air filters and the symptomatic winter respiratory infection episodes, including COVID-19. Now, the research isn't over yet, so I don't have any results for you, but Nightingale House was randomly selected as a control group. So even though they didn't receive the air filters, they still provided a lot of help into the research. And I taught staff members how to perform standardized tests, such as fragility tests. So I supported Bristol University in doing this study, and Nuno, Betty from housekeeping, and Michelle were all very involved in the study, and they also helped deliver. So if you have any questions about what we do, please come speak to us at lunch. Thank you.
Hello, everyone here and the online audience. So my name is Saif, and I'm one of the researchers at UCL, and we are doing this topic trial along with my colleague Sana, and it's a fancy acronym which stands for Improving the Oral Health of Older People and Care Homes. So just to give so this is led by Professor George Sakos here, who's with us, and just to give a brief recap of what we did. So we did a randomized control trial to determine the feasibility of this co-design intervention based on the NG48 guidelines. So these NG48 guidelines are NICE guidelines which which provides guidance basically about aspects like daily mouth care and to improve oral health in care home. So we co-designed this care home oral care toolkit, and it basically contains of this oral health assessment tool, this personal oral care plan, and weekly oral hygiene record. So this can be carried out by the care home staff. And so what we are also doing along with this trial is we are carrying out this theoretically informed process evaluation. What this means is we are looking at what worked, what didn't, and what are the barriers, facilitators, and whether the intervention reached the target, which are the residents. So all those things. And how did we do it? So we carried out semi-structured interviews with the care home staff, the managers, and also some of the residents. And we used this Fahrenheit et al. Framework, which is a theoretical framework. And when we were around halfway, we realized we are not capturing everything. So we did a reflexive workshop where researchers like me and Sana that were involved in the trial, we were taken as participants, and the wider research team, they did the interview, and we tried to capture the key findings that we were seeing during our visits there. And then what we realized that the framework shifted a bit from this Fahrenheit et al. To the system lens. What it means is that there were various factors that were influencing at different levels. So Sana will be talking about the findings in detail. So without wasting any time, I'll just pass it over to Sana.
Hello everyone, I'm Sana, and I'll share the study results with you. Not the study results, the results of process evaluation. So the results are presented according to the elements of the hierarchical system lens. Firstly, it's the paradigm and goals. All the managers that we interviewed expressed a strong desire to participate in the study, and this mainly came from the difficulty that they experience in accessing care for the residents, and also their interest in improving the staff knowledge about oral health. And second, here are some of the quotes that are extracted from the interviews that we did. Secondly is the system structure. The uptake of intervention was largely idiosyncratic across all the care homes, and the organization and efficiency of processes within each care home varied greatly from the other. And there are a wide range of factors that are responsible for this idiosyncrasy. One of the reasons is the time poverty. In the reflexive workshop, one of the researchers reported these people, meaning the care staff, are so overworked. They are very well motivated, they just don't have the time to do the study. Similarly, the care staff are having to cater for competing needs. Due to lack of time, they are having to prioritize one task over another, and they are doing what they feel is important for their resident at that very moment in time. So, and another thing that was identified was the staffing issues. One of the care staff that we spoke to reported there is a staffing issue. If you don't have enough staff, it becomes difficult for them. And to keep up with the oral health training of the staff, it becomes really difficult for us as researchers as well as the management when the staff turnover is so high, which seems to be the problem with almost all the care homes in the country. So that's it's a few of the many challenges that we faced in this. And then moving on to the structural elements. The intervention was generally well received by the residents. However, it was considered important for the care staff to have a good relationship with the residents in order to facilitate this. So, as you can see, one of the managers said, so I have to have these lovely conversations and promise him I'm going to marry him tomorrow. So we have to bear in mind almost all of the residents have some degree of cognitive impairment. So bearing that in mind, we need to develop that rapport that is needed to deliver the care that they need. And in the third quote, it says, I'm getting a bigger picture. I'm getting to understand who actually brushes their own teeth. In this quote, the manager is referring to one of the items that we gave in the intervention kit, which was a daily toothbrushing log. The staff records there whether or not the resident has brushed their teeth. So this gave the management a good oversight of the oral care that the residents were receiving or not receiving at all. And then lastly, feedback. This level of system lens refers to the various processes that are used to maintain stability and status quo, and the key finding at this stage was that of excessive paperwork. Although the staff and the management greatly appreciated and valued the intervention kit that we gave them, but the amount of paperwork that came with it seems to be a burden for them. And the staff that we spoke to highlighted the importance of integrating anything new, like an oral care plan, into the existing care plans and routines that are there already in place. So to summarize, our study documented a wide range of factors that can affect the implementation of an oral health intervention in care home settings, and the use of system lens enabled us, the researchers, to account for the hierarchical and idiosyncratic nature of things in the care home settings. Thank you so much.
Hello, everybody. Thank you for the opportunity to present to you today. My name is Claire Ellis-Smith. I'm a lecturer in palliative care at King's College London, and I'm going to be presenting to you I'm presenting two interlinked studies on strengthening palliative care for people living in care homes. And the reason we did this work is really with the recognition that many people living in care homes are in the last few years of life, and they're approaching the end of life, and many will live with palliative care needs, so physical, psychosocial, and spiritual care needs due to living with multiple chronic conditions, due to frailty, due to cognitive impairment. So the majority of residents we anticipate will have some palliative care needs, even if they're not at the end of life. So we presented I'm presenting the results of 2 research projects. And the first was really to understand a little bit more about palliative care, or how to strengthen palliative care in care homes. And we did 15 interviews with health and social care practitioners. And we had 4 themes related to this. So the first, and I think everybody in this room knows this and everybody online knows this, but really recognizing the highly skilled and demanding work of care home staff, and that actually they're living with people, looking after people with complex care needs right towards the end of life and into death. So that really there's a real need for good support around care home staff. Also, that there's huge variability in accessing palliative care. And so there's some cases, and some care homes have really good support to primary and specialist care, but lots of care homes are much more isolated in being able to access care. So, so this is very, very variable, and even in kind of quite local areas, this can be dependent on relationships or kind of champions. And then and there's a lack of accountability, so there's a lack of named person in providing palliative care. And then also the importance of detecting deterioration, so that actually some people might be very obvious in their deterioration, but some people may have undetected needs. They may not be able to vocalize it, they may not be able to communicate it, and there may be just gradual deterioration or undetected discomforts that they could benefit from a palliative care approach. We then went on to do co-design workshops, and we did co-design workshops with family carers with experience of looking after people in care homes, as well as social and health practitioners. And there were 3 themes related to this. So the first, and again, not new to you, is the importance of person-centered and also culturally specific and congruent care. And really kind of the need, and this resonates with so many presentations already, but the need of engaging with the community. So actually that the community addresses some of the really important social and spiritual care needs that residents may have. There's a real importance for multidisciplinary care teams so that individuals have access to all those who might be able to address palliative care needs. And this is not just specialist palliative care. This is primary care, geriatricians, allied health professionals who might be able to address palliative care needs, and the importance of champions as well. And then really speaking to the importance of detecting deterioration is the use of standardized and structured care processes. So really kind of being able to use systematic assessment and monitoring processes to assess and address individuals' needs. And actually it needs to be transparent, and it needs to involve family members. Family members really spoke about the importance of understanding what processes were in place so they could be engaged in those processes. And then finally, building upon this work, we did some work in implementing a person-centered outcome measure in routine care to support the standardized processes. And really this talks again to a lot of outcome measurement that that's already been discussed today. But really using a person-centered outcome measure in routine care, we asked care home staff to do that, and we did some focus groups understanding their experiences. They told us that it really supported holistic assessments, understanding person's need, and providing a structured way of identifying and also sharing information within and between care home staff, but also with external practitioners. It provided a standardized language for communicating, again, kind of within the care home and externally, and a systematic way of assessing, and importantly, picking up and assessing deterioration, identifying needs, and enabling management of those needs. And I think that is my last slide. So thank you very much.